For decades, cardiovascular prevention has been built around aerobic exercise prescriptions. Clinicians prioritized oxygen delivery and heart rate to protect the vascular system from decay. Large-scale prospective cohort data is now challenging that singular focus. An analysis published in the Journal of the American College of Cardiology pooled data from 117,025 female nurses over a 14-year period to isolate the impact of strength training. Women performing at least 2 hours of resistance training per week experienced a 20% lower risk of incident major cardiovascular disease. For myocardial infarction, risk dropped 44%. These outcomes persisted after adjusting for BMI and metabolic conditions, suggesting mechanisms beyond fat reduction. However, these benefits were only present in women who consistently maintained the habit. Subjects had to meet training thresholds in at least 75% of the assessment cycles over the 14-year follow-up to show a statistically significant risk reduction. Strength training acts as an independent, highly potent modulator of clinical cardiovascular risk, regardless of a patient's aerobic capacity. Moving from population data to the microscopic cellular level reveals exactly why mechanical tension produces such a strong systemic effect. During contraction, skeletal muscle acts as an endocrine organ, synthesizing and secreting signaling peptides directly into the circulatory system. These peptides, known as myokines, facilitate communication between the muscle and the rest of the body. This diagram maps how specific myokines like FGF21, decorin, and follistatin move from the fiber to their metabolic targets. Resistance training induces an acute post-exercise spike in fibroblast growth factor 21, a key regulator supporting insulin sensitivity and glucose utilization. As workout intensity increases, contracting fibers also release decorin and follistatin. Follistatin functions as an inhibitor of myostatin and TGF-beta1, proteins that typically limit muscle growth. In experimental models, this inhibition pathway appears to limit the proliferation of pre-adipocytes, precursors to mature fat cells. By potentially limiting visceral adiposity, these myokines reduce the primary drivers of systemic inflammation and sympathetic overactivation. Clinical trials observing interval resistance training confirm these shifts. Increases in these myokine concentrations correlate with improved lipid profiles, including significant increases in HDL and decreases in LDL cholesterol. Lifting weights biochemically re-engineers the body's metabolic sink, modifying how the system handles glucose and stores fat. While the biochemical benefits are substantial, they are generated through severe hemodynamic stress. Every heavy set acts as a mechanical pressure test for the vascular wall. This anatomical map distinguishes between two domains of arterial stiffness: the central elastic arteries, like the aorta and carovents, and the peripheral muscular conduits. Low to moderate intensity resistance training generally improves vascular health by decreasing systemic pulse wave velocity, which indicates more compliant elastic peripheral vessels. High-intensity training creates a different condition. Straining against heavy loads generates massive transient spikes in intrathoracic pressure. These pressure surges, combined with heightened sympathetic activity, acutely increase central arterial stiffness to withstand the lift's internal force. Upper body training exacerbates this effect. Because the vascular bed in the arms is smaller, it creates higher relative peripheral resistance, reflecting a larger arterial wave back towards the aorta. Age-related structural changes make this stress even more significant. Over time, elastin fibers in the central arteries fragment and are replaced by rigid collagen. In hypertensive patients, where adaptive vascular compliance is already compromised, these acute pressure spikes place an even higher mechanical load on the strained system. These hemodynamic surges represent a mechanical trade-off for the biochemical advantages of myokine signaling. Heavy lifting forces the central arteries to absorb a massive mechanical load, creating a physiological cost that scales with the intensity and volume. This mechanical stress on central arteries directly influences long-term survival rates, setting a clear limit on how much volume the body safely tolerates. This graph tracks mortality hazard ratios relative to weekly resistance training duration. It combines 30 years of follow-up from 147,000 participants in the BJSM analysis with specialized spline models from the Women's Health Study. The data reveals an optimal operational range between 90 and 120 minutes per week, associated with a 19% lower cardiovascular mortality risk. Beyond 120 minutes, survival benefits plateau, showing no statistically significant additional reduction. For older, initially healthy women, the relationship between volume and health becomes more complex. In this population, the curve takes on a J shape. At 146 minutes per week, the mortality risk begins to climb, crossing back over the threshold of 1.00. High volumes were associated with risks similar to performing no strength training. The likely explanation is that age-stiffened central arteries are repeatedly subjected to the high-pressure surges of excessive training volume. Repeatedly subjecting these vessels to acute wall stress may contribute to subclinical myocardial fibrosis or arterial damage. This indicates a biological saturation point where increasing training volume no longer yields cardiovascular benefits. Excessive strength training volume can mechanically strain the central arterial matrix, potentially counteracting the systemic benefits of the exercise. The challenge for clinicians is to maintain the metabolic benefits of resistance training while protecting the central arteries from these acute pressure surges. The cardio race trial and related hemodynamic studies show that the vascular response to a combined exercise regimen is highly dependent on the training sequence. Following a heavy resistance session, the central arteries exist in an acute state of stiffening and constriction due to the preceding pressure spikes and sympathetic activity. If that lifting block is followed immediately by aerobic exercise, the vascular system begins to pivot. The rhythmic movement of aerobic exercise creates sustained shear stress on the vessel walls, triggering the release of nitric oxide. This promotes vasodilation and helps relax the central arteries. Order is the determining factor. Studies indicate that performing aerobic exercise before resistance training does not prevent the central carotid stiffening that occurs during the subsequent lifting block. Concluding the session with aerobic exercise helps relax the central vessels, attenuating the transient stiffening caused by heavy lifting. The most significant cardiovascular risk reductions in the JACC cohort were found in women who balanced these movement patterns. The clinical gold standard involves accumulating 150 minutes of aerobic activity, combined with 60 to 120 minutes of resistance training per week, while actively limiting sedentary behavior. Within this model, resistance training serves as the body's primary metabolic engine, preserving lean mass and driving myokine transduction to regulate blood glucose and inflammation. Aerobic exercise provides the structural counterweight, maintaining central vascular elasticity and providing the nitric oxide release necessary for vascular recovery. Maximized longevity requires a specific synergy, mechanical tension to drive myokine signaling, and aerobic volume to maintain structural vascular compliance.